Okay, GIT, we're going to talk about gastric acid composition and secretion, the abdominal pressure and reflux control, the lower esophageal sphincter, and the process of swallowing and vomiting. And liver, just now I missed out. Liver also has been asked few times in SAQ, but I think the last one is in 2011, 2012, something like that. But not as a full SAQ question, not 10 marks, like 4 marks, something like that. So you should know it's all these are not much to understand, just all facts to remember. So your GI tract starts from all the way till to your anus. We are not going to talk to this anus. We're going to stick to here. And I'm not going to talk about digestion, absorption, all that under metabolism. And I don't think it came up before SAQ. I went through until 2010. I didn't see any questions on, write a short note on metabolism of carbohydrate. No, digestion and absorption of carbohydrate, all these enzymes and everything. Okay? Unfortunate, might come out for you all. So, so the GI tract, that the four main things that important is, one is the motility of the GI tract all the way from your oral cavity until your anus, digestion, absorption, and secretion. Okay, digestion and absorption, we're not going to talk much. We're going to talk about motility and also the secretion. So GI secretions, this used to be a famous question, last time in MCQ, by my time, even when I'm sitting for MCI, they will give this, how much is coming out, right? So nowadays in SB, I don't know how to ask this. How can they ask this? I don't know how much come out in gastric, how much come out in spine. Last time MCQ got following the composition of volume of gastric juice according to their site. You must know roughly. Okay, so just want to highlight here, your gastric secretion is almost 2000 ml per day. If you divide it by 24 per hour, roughly around 80, right? 80 mils, right? Minimum, right? So 4 jam is 320 mil, right? One time aspirate 100 mil. Oh, patient aspirate cannot lah. Intolerance. Stop feeding. It's like, what? Seriously? Then straight away for 8 hours. Next one still got 50 cc, doctor, I stop. They expect 0, is it, every time? Cannot lah. You read the ICU protocol also, it's what? Say what? 300, you return and continue feeding. 500 only you stop. Right? 300 you return. It's belong to patient, There's some staff nurses have some code. Aspirate is the patient's rights or something like that, they always say. It's written in their nursing guideline. So something that you cannot buang, You have to give it back to the patient. Okay? Unlike blood, different lah. Okay. Okay, so that's about it. And then this is important. Your pH, why I want to tell you is because when we take food in oral cavity, it's alkaline. It's basically neutral to alkaline. When you go into your gastric, you see how acidic is it. It can go up to 1.5 to 2.0. The pH is very acidic because of hydrochloric acid. Then, because of the pancreatic juice and bile, it becomes alkaline again. And then it goes back to neutral and almost alkaline when it comes out after the water has been reabsorbed and everything, mostly. Okay. What is the importance of 1.5 This is why the aspiration of gastric contents is very severe. Okay, imagine pH of 1.5 or 2 goes into your lungs. Okay, it will cause chemical pneumonitis. What is it called? What is the syndrome called? What? Yes, Mendelssohn syndrome. How much is enough to go in? How many meals? They said up to 5 meals is enough. Okay, if patient is fasted, really fasted, when you're fasting, there's only hydrochloric acid in your stomach, right? If it goes inside, yes, that is the reason of giving aspiration prophylaxis. Try to neutralize. Okay? Okay, your gastric juice composition, I just want to highlight this. So it does enzyme, it does other organic substances, and it does inorganic substances as your electrolytes mainly. Okay, concentration of hydrochloride can be up to 150 milliequivalent per liter. Okay. Okay, gastric secretion is controlled by 3 phases: cephalic phases, gastric phases, and intestinal phases. Okay, we are talking about only stomach, gastric, but the secretion starts way before the food reaches the stomach. Okay, it starts from your oral cavity. It by your cephalic means from the brain, based on your smell, odor, the taste, and everything. It's already give a signal to the stomach to already secrete something. Then it goes to your gastric phase when the food actually reaches the stomach. And once the food is leaving the stomach into the intestine, it still gives some input to the stomach. for the residual food, whatever. Okay, so what is important here is cephalic phase is mainly by neural, vagus. There's no hormones involved. Okay, it's purely by vagal, neural. But gastric phase is neural plus chemical. Okay, and then your intestinal phase is also both, but mainly hormonal. Okay, so cephalic phase may only nervous. So it's a condition or unconditioned reflex. It's all by your senses actually. It's not actually by, it's mainly by your brain getting your senses. It can be sensed from an odor, can be taste and everything. So it sends a stimulation to vagus nerve, vagus sensor. So this is your vagus trunk, local nerve plexus, enteric nerve plexus. What's back, our back plexus, something like that, right? I forgot. Okay, so that plexus will give all these things. Okay, that is from your cephalic phase. Next, your gastric phase is nervous and hormonal, which involves your vagus nerve, local nerve, and also gastrin. Okay, stimulation of your gastric juice. The outcome is same. It's secretion of your gastric juice. It's not only hydrochloric acid, secretion of gastric juice, whatever compensation I told just now. Then finally, your intestinal phase is mostly hormonal. So nervous, hormonal, and hormonal. So regulation of gastric acid secretion, if you're able to write this itself, you already get 2 marks. 3 phases, what are the phases involved? Okay. So this is the question that I came on, but this is from Matthew Ho. I like that fella a lot, Matthew. He made my life easy during primary. I just print out everything and memorized all the SAQ. And went for the exam, done, settled. He gave everything in a simple form already. So he say he done all this for you already. Okay, just go and you all aware of, right? Aware of Matthew Ho, right? Yeah, there's Amanda Diaz and Matthew. Amanda Diaz is too complicated. Girls, right? Too complicated it is. Everywhere point form. I cannot. This fellow is okay. I think he's a guy, he cannot think much. It's very simple. He said, let me put it in words and tables. So at least next time I look back, I remember, this is what I did. Yeah. If I did what Amanda Diaz did, next time I look back at it, I have to rewrite again. I don't understand. So that's how it goes. Okay. Okay. So gastric cells, again. So another short question came out. What are the gastric cells? Just now we talked about the regulation of gastric juice secretion. So what are the cells that involve? Okay. So cells that involve, you have mucous goblet cells, which is at the end, which has the pylorus there. Correct, right? This is the pylorus. Okay. Mucous goblet cells, they secrete mucus and bicarbonate. So that's why you see when the food is leaving the stomach, they are reaching alkaline, from acidic to alkaline. Okay. It's all based on the anatomy. So they have physical barrier between buffers gastric acid, blah, blah, blah. Okay. Then the important is your parietal cell, which actually secrete your hydrochloric acid and receives input from many chemicals to secretion of your gastric acid. And parietal cell also secrete intrinsic factor for your vitamin B12 absorption. Then you have your enterochromaffin cell, which secrete histamine, which is stimulated by your acetylcholine and gastrin. You see, all these cells receives this parietal cell, enterochromaffin, they all receive a stimulus from another chemical. That's why your gastric is hormonal and neural. So hormonal plays a very important part. So it is enterochromaffin cells secrete histamine, stimulate gastric acid. Chief cells, they produce pepsin and gastrin. Chief cells are mostly for enzymes. They're for digestion. Okay, their digestion. Then your D cell is somatostatin. All the others stimulate, only the D cells inhibit. Okay, they are the only enemy there. Okay, then finally you have your G cell, which secrete the main thing, gastrin, which stimulates your gastric acid secretion. Clear? Move on. Okay, we talked about it. Okay, come here. This is the repetition. You can see how they produce. Only other inhibitors are VIP and GIP. What is VIP? Vasoactive intestinal peptide. Okay, GIP, I don't know. Gastric intestinal peptide, maybe. Okay, so we talked about, we see only this is inhibitory, others all are stimulatory. So gastrin works via GQ receptors. Acetylcholine, GQ receptors. Then you have your histamine, you have GS receptors. Then you have PGE2 works via GI receptors. Why? Prostaglandin does not stimulate the gastric secretion. They inhibit. They are protective. They are the protective layer. Okay. So this is why I always Another favorite topic of mine in pharmac is G-coupled protein receptors. If you don't know G-coupled protein receptors, don't go to primary. Every single drug you read, 90% of it will related to G-protein coupled receptors. If you understand G-protein coupled receptors, you don't have to memorize it. You will know what does it do, how does it do, what are the things that gonna come up. Okay, sit and read G-protein coupled receptor a few times, watch all the videos I've shared. Those who are in my class, I've shared some videos, animation. Enough, you will understand all this. So since I know what this do, I don't have to look at this now. I can just omit this. Because I understand what GQ does, GI does, GF does, right? So you know already. So then we go to the, all of them will stimulate, this is your parietal cell to stimulate acid, hydrochloric acid secretion. So again, Matthew has done the work for us. Please go and look at it. Okay, well, I've written all these things, but don't write this much in SAQ, you won't have time. Concise it a bit more. Okay. So next we come into, once they have stimulated, there is a regulation. Somebody is giving them the order. The cells are working. They are producing some chemical. Now the cell have to produce the hydrochloric acid. Okay, the engine already started. So how does it work to produce the hydrochloric acid? You have to know this. There will be a short note on hydrochloric acid formation by parietal cells. Keep it simple. It's going to be 2 marks, maximum 3 marka, 0.5 mark, 6 sentences, 7 sentences, more than enough. Anyone want to draw? Draw. I'm sure you cannot go to the next question. Okay. So first, you have CO2 in your blood. Okay, carbon dioxide in your blood will diffuses into your parietal cell via active transport. Active transport, is it? Carbon dioxide is very highly soluble, right? Yeah. Okay. So it diffusion, so it combines with water and then it catabolized by your carbonic anhydrase. Okay, carbonic anhydrase. Carbonic anhydrase can form bicarbonic acid, right? H2CO3. It also breaks down H2CO3, right? How? One enzyme, how can it do it? This is carbonic anhydrase 2, that is 4. There are 4 types. Okay. I got to know yesterday, that's why. I was thinking as well, how does it do? Okay. So H2CO3. So H2CO3 inside the parietal cell. So CO2 plus H2O. So this is carbonic anhydrase 2. Then H2CO3 will cleave. Okay, this is not enzyme related. This is just H2CO3 being break down into bicarb plus hydrogen ion. Okay, so bicarb will get transported back into the blood. Okay, transport back into the blood with the bicarb chloride symporter. And the H plus will go into another antiporter. This is symporter. Okay, the one that bicarbonate moving back to the blood is symporter with chloride. Whereas the antiporter, it's a proton pump. It's an antiporter, right? Against the concentration gradient, it's ATP driven. Okay, so it will go with potassium. Potassium comes here, hydrogen goes here. It's an exchanger. Okay, potassium is usually high intracellularly, right? So it should actually go out, right, from the cell to outside. So it's going against the gradient. Okay, so that's why I'm telling you. So it's going against the gradient. Okay. Antiporter in the plasma membrane exchanges carbon chloride ion. Sorry, this is not antiporter. This is antiporter. Yeah, let me correct myself. Oh yeah, this one also antiporter lah. Okay, sorry. It's an antiporter as well. So it exchanges the bicarb for chloride ion, and then your H plus K plus proton pump moves H plus into the duct or gastric gland and K plus into the parietal cell. Okay, then chloride ion diffuse with the charged H plus. Your chloride goes out here. Okay, chloride comes to the parietal cell and then goes here. Okay, this is how it forms. So if you want to give proton pump inhibitors, your omeprazole, everything, so they directly will inhibit here. When you give H2 blockers, they will inhibit. Which one is better, H2 blocker or proton pump? Why? So the proton pump is inhibiting the final pathway. Whereas if you give your histamine blocker, it's only going to inhibit here, right? All these are not inhibited. They got other stimulus to produce the hydrochloric acid. Okay, next, abdominal pressure, normal pressure 10 to 10 centimeter water. Lower esophageal sphincter pressure. Okay, your intragastric pressure at rest is 10 centimeter water. Okay, so but your lower esophageal sphincter, it has a higher pressure to prevent reflux from your gastric content. It's 30 to 40 centimeter water. So the barrier pressure is sphincter minus the intragastric 20 to 30 centimeter water. Okay, if this pressure is maintained, there is no reflux. If the pressure drop below 13 centimeter water, 15, I can take it as 15 as well. So the reflux can possibly can happen. So that is the idea. So that is about the lower esophageal sphincter. So why is it so important to know about this lower esophageal sphincter? It is very distinctive, as in it can only contract. It has only as muscles to contract. The dilation is passive. It's same like your diaphragm. Inspiration is active, right? We don't do anything to expire, right? It's a passive process, right? Something like that. Okay. So the anatomy is between, it is just the entry point into your stomach, esophagus to your stomach. So the reflux control, the anti-reflux barrier is at the lower esophageal sphincter and gastroesophageal junction over here. So lower esophageal sphincter is at a high pressure zone. It's a 20 to 30 centimeter water, that is the transition zone. Smooth muscle, which is tightly contracted. At all time is tightly contracted. Okay, unless there is a stimulus of food bolus going in. Okay, or you're putting in an NG tube. So putting in an NG tube prevent aspiration or increases aspiration. So patient with ileus, patient with IO, is safe to put in a, or not safe to put in? Patient has intestinal obstruction. The patient is okay. He's sitting, he's just sitting. Diagnosis is intestinal obstruction. You want to put in or don't want to put in NG tube? It's very controversial because we are not measuring the barrier pressure. Okay, as long the barrier pressure, yes, IO. If its intragastric pressure does not exceed the LES pressure, you won't have reflux. You won't have aspiration. Correct. But when you insert an NG tube, what are you doing? You're opening the LES pressure. You're opening the lower esophageal sphincter. Right? You're forcing it. Do you realize that's why sometimes in a patient who are not relaxed, you can't push in your NG tube. It will stuck because it's tightly contracted. The patient, that's why I ask them to swallow, swallow, swallow. So when they swallow, the saliva is going in as mimicking the food bolus. So that stimulates the lower esophageal sphincter to open up, then the NG tube can. Understand? So that is the. So it has protects the esophagus from reflux or gastric content. It has no dilator muscles. I mentioned it's only F muscles to constrict. Direct inhibitory signals allow the smooth muscle in the LES to relax, allow food bolus. It's a direct inhibitory signal. Okay, it's a direct inhibitory signal to stop the muscle from contract. There is no stimulus to dilate. Okay, it's a two different thing. Usually we have a signal to contract, we have a signal to dilate, like sympathetic versus parasympathetic. Right here, no. Its work is always to be contracted. When there's a signal to contract, it's not there, they dilate. But there is no signal to dilate. That's the difference. Okay, so it has two components to maintain this physiology. One is the intrinsic component by the esophageal muscle fiber. This will read about it. There's some Pinchcock mechanism, class, all these things. Then it is under the neurohormonal control. Extrinsic component is the anatomy. Is all this anatomical part, which is diaphragmatic crura, pinoesophageal ligament, and which is provide the anatomical support. Somewhat similar to diaphragm also. Okay, it's all related to someone nearer to diaphragm. So two mechanisms. Myogenic control, intrinsic rhythm of smooth muscle contraction and relaxation, and neural control, autonomic and enteric nervous system. If they ask you to write a short note on LES for Tiga Marka, this is for them. Okay, if you fail to mention about this muscle fibers type and everything, you might lose another 0.5 marks. That's all. Okay. So LES tone factors increase and decrease. It can be neural, hormonal, drugs, physiological, and pathological state. Please do your homework and come out in your SPA. Okay, what is the physiological state that relaxes your alias? Physiological state. Pregnant is pathological. Asatu. Right. Asatu, right? Pregnancy is Asatu, right? Asatu means they're not physiological, right? No. Pregnancy is a disease. As in like consider asala. I mean you are not physiology, right? A lot of physiology is altered, right? In that sense, okay? Don't sensitive. In that sense. Smoking also a disease. Right? Asatu, right? Smokers are actually disease people. Okay? Okay. So please do your homework on this. Okay. Any drugs that relaxes your alias? Okay, okay, go do homework. Okay. Okay, next. Coloring, short note, might come out 3 markah macam tu. You have to mention there are 3 phases. First phase in the mouth itself, second phase over here, third phase in the esophagus. Okay. So food is moistened with saliva and chewed. A rounded mass of food bolus is formed. Then tongue pushes the bolus to back of the throat. So from here, it goes to the back of the throat. Okay. So bolus is now here. Next, bolus stimulate receptor at the back of the throat. Tongue stops bolus from going back into the mouth. Okay, that is the first thing. The tongue stops fruit bolus from going back into the mouth. Second, back of the throat moves back to the airway from the nose. A small movable lid epiglottis covers the windpipe. This is next. Epiglottis closes the first. Tongue stops the upper part. Now the epiglottis closes the lower part, airway. Third, bolus move into the esophagus. So muscular contraction move down the gullet. Epiglottis uncovers the back of the throat, moves to block. So we see here. Make it simple. First, bolus of food. You have upper esophageal sphincter is closed. We have another one, upper esophageal sphincter as well. Okay, but for our anesthetic is not so important, I think. That's why not asked in exam. Okay, so next, this is the part where all the important things happen to prevent aspiration. Okay, first, you have tongue blocks the oral cavity. Then soft palate blocks the nasal cavity. Okay, you have your oropharynx and nasopharynx, right? So 2 parts, both the pharynx has been closed. So now only the lower part. So the airway should be closed as well. That's what does the epiglottis does. Epiglottis blocks the larynx. So nasopharynx by your soft palate, oropharynx by your tongue, and your airway by your epiglottis. Okay, then food goes downwards. Then upper esophageal sphincter closes. So initially when the bolus comes here, upper esophageal sphincter open, food goes in, upper esophageal sphincter closed. So that prevents the food going back to the mouth, only moving downward. Okay, again, the floor has done the homework for us. Please go and read. Okay, so you have to mention this part lah, the afferent, controller, and efferent. This is your opening. Then you have to mention this phase. You can make it simpler and everything lah. Okay. Okay, vomiting. Vomiting. Is vomiting and regurgitation the same? Which one is active? Which one is passive? Active means voluntary. Voluntary? Vomiting is voluntary. So it's active. Active or not is based on the muscular contraction. You don't get it confused, okay? So it's an active, involuntary retropulsion of gastric content. That is your definition of vomiting. Define vomiting, active, involuntary retropulsion of gastric contents. Okay? Involuntary, forceful, another one, forceful and rapid expulsion of your gastric content. I use the word retropulsion, like mean coming back. Okay, it's an active process. Okay, so you need to have a stimulus for vomiting, and the stimulus must reach the center, the control center. Okay, the efferent. From the control center, there must be a relay to reach the effector, which is your stomach and your diaphragm. Okay, okay? Regurgitation is a passive process. Nausea is a prodrome, which associated with vomiting is unpleasant conscious sensation. Okay, stimulus. Alah, kedai RM2 punya duster. Patutlah. A tissue paper. I think this will take until. That me? I didn't do anything. Is it me? Mic is here. Okay, tissue. Oh, thank you, thank you. Sama juga. Memang payah. Thank you, thank you. Ada. Nah. Thanks. Thank you so much. Bahasanya. So after this, I can't use the whiteboard. This is the second time, then done. Okay. Where is the vomiting center? Everyone can hear me, right? I don't have to hold the mic. Where is the vomiting center? What is the vomiting center called? Salah. Chemoreceptor trigger zone is a relay to vomiting. It is not the vomiting. It's the name as suggests, chemoreceptor trigger zone. It triggers the vomiting center. Okay, so you have vomiting center in brainstem, especially at medulla oblongata, dekat reticular formation. Okay, which is inside the blood-brain barrier. Dalam. Dekat luar sini is your chemotrigger receptor zone. Chemoreceptor trigger zone dekat area postrema. Just now you all told me, right? Okay, so this guy is the main controller. This fella is a signaler, just to signal. It's a relay. Okay, understand? Okay. So this is your BBB. Okay. What are the stimulus for your blood-brain barrier untuk vomiting? Someone? Anyone? Smell. Okay, so higher center. Higher center, you have your smell, emotion, sight, pain. Right? So all that higher centers are inside your blood-brain barrier, right? So direct. Okay. Next. Anything else? Stimulus? Sorry. Vestibular. Okay, good. Vestibular system by your activation of your labyrinth. Right. So you have your vestibular cochlear nerve. Okay, cranial nerve 8 to directly stimulate this, and they can stimulate this also. Okay. Something else? Other stimulus? GI. Bowel. Right? By your cranial nerve 9 and 10. Vagus and glossopharyngeal lah. Okay, they can stimulate vomiting center directly via the nerve or via chemical mediator. Right? Chemical mediators goes via bloodstream, right? Bloodstream cannot pass through here. So they have to stimulate this fella, and this fella will stimulate this. Okay? What else? Your heart also can lah. Patient with MI, right? MI get vomiting, right? Patient with also. Okay. What else? Drugs. Drugs, toxins, whatever lah. So, okay. So now we have to know is what receptors involved where, right? So we can give our antiemetics, right? So vomiting center is mainly your NK1, which is your, and then M, muscarinic receptor. Okay, muscarinic receptor and NK1. So you can give any anticholinergic, or NK1 is aprepitant. Have you all used aprepitant before? It's an NK1 antagonist lah. I find antiemetic lah. I also never used before. Never. So aprepitant. Okay. Some claim 5-HT3 also here. Most of them say no. Okay. So here is you have your M, NK1, D2, and your 5-HT3. Okay. So that's why they say if you have chemotherapy-induced vomiting, okay, and you give anticholinergic, it's not so effective because they mostly involve 5-HT3. Understand now why how we choose the drugs and everything? But you have bowel related, we give anticholinergic, right? Buscopan. So because it's directly to muscarinic. Dekat sini you bagi Kytril, maybe no, maybe not. That's why they say 5-HT3 might work, might not work. Okay, so that's how it works. So here, vestibular system is mostly M and histamine. Yes, for motion sickness. That's why we give antihistamines, scopolamine, and then you cetirizine, whatever lah. Okay, this can be everything. Drugs, right? Drugs can be anything. So you can be all these things plus your age also lah. What drugs depends on give. Okay, any emetic drug can go and stimulate this. For any toxins can stimulate patient to have this. Higher centers, usually these are all like neurotransmitters, like GABA, D2, all these things lah. Sometimes the opioid mu receptor also directly from there, they say. All these hypotheses, postulation. Okay, done? Okay. So this is what I said. This is the summary of it lah. You can see what drugs they gave where and everything lah. Okay, I will share this slide later. Okay. Okay. Next question will be phases of emesis. Just now we talked about phases of swallowing. Now phases of emesis, also tiga phase. One is prodrome, which is the feeling want to vomit. Next is the retching, the retropulsion of your stomach content into your esophagus. You get your heartburn and everything. Finally is the vomiting. So you just have to write as simple as this is enough. Phases of vomiting, 3 phases. Prodrome or nausea, imminent need to vomit associated with gastric stasis. Retching, labored movement of abdomen and thoracic muscle, may or may not associated with heartburn. Vomiting, forceful expulsion of gastric content, GI retroperistalsis. Yeah. Enough. 0.25, 0.25, 0.25, 1.5 to 2 mata. Okay, the question will ask to define first. Okay, we are trying to tell the whole examination. But the Cairo is young, okay. Uni trying to tell we don't want to put 0.25 marks for SEQ. There's no 0.25, 0.25. It's actually make the examiner's life easier to give marks. It's either 0.5 or 1, like that. So just give questions that can give 0.5 marks directly rather than 0.25, 0.25 here and there. So it's very difficult to mark and very difficult to actually get the answer from the candidate. If I don't know whether we'll accept it or not. Okay, very simple. Okay. So next, act of emesis. Act of emesis start from your stimulus to your vomiting center, then vomiting center coordinate. This is, I said, the controller. Okay, right? So stimulus is your afferent, right? Afferent goes to your controller. Then controller, number 3 would be hypersalivation. This is your nausea, right? All the prodrome. Then number 4 will be the process that occurs before the vomiting. So glottis clauses. Glottis clause to protect your airway from aspiration. Then soft palate rises to close the soft airway. As I mentioned, nasopharynx and airway is closed. Oropharynx cannot be closed lah, then cannot come out right. Okay. So then deep inspiration, diaphragm contracts. So this is important. Your breath will be held in mid inspiration when you vomit. Okay, it can come out in exhale. Last time very famous in institute. Your breath will be held in early inspiration, inspiration. I don't know why so important. Ideally for us to remember that. Okay. Then number 6 will be gastroesophageal sphincter and fundus of the stomach relax. 7, abdominal muscle contract forcefully, anti-peristaltic wave. This is important. If the peristalsis is still going on, then the food will go towards the anus, won't come up right. So despite all these occurs simultaneously, there is stop of peristalsis, then finally increased pressure or forces time upward to stomach into the mouth. Okay, these are the flow. Okay, again, people has done the work. Please go and do this. Okay. Okay, liver, another 5 minutes. Okay, liver functional anatomy. We have right hypochondrium, 1,500 grams, 2 lobes, right and left, 8 segments, 1,000 lobules. Okay. Important part is the anatomical unit. We have anatomical and functional unit. Anatomical unit is called as hepatic lobule, and lobule as portal triad. Portal triad is hepatic artery, portal vein, and bile duct. Okay, liver blood flow is quite peculiar, so you have to know this. The portal vein and hepatic artery both supply blood and oxygen to people, even though it's called vein. Okay, so functional unit is called sinus. The importance of knowing a sinus is they have 3 zones: periportal, portal, and centrilobular. The periportal receives the highest oxygen because they're metabolically active. They synthesize a lot of things. And centrilobular, lower oxygen, despite they having a lot of enzymes, but the oxygen extraction is lower, okay, in the centrilobular. So the liver blood flow, as I mentioned, it receives from hepatic artery and your portal vein. Portal vein receives the blood from all the splanchnic circulation organs. All these are splanchnic circulation, and then the blood goes to the liver via portal vein. Hepatic artery is directly from your aorta, ciliary artery, and hepatic artery. So blood receives liver receives blood circulation from hepatic artery and portal vein. So it receives 25 to 30% of cardiac output. Okay, one of the largest, right? Is it the largest? Which is the largest organ in the body? But the skin receives the largest? What receives largest amount? Lung? Kidney? Tadi kita tengok orang ni yang saya kata. All the time? When you exercise? Muscles, right? Yeah. So these are the questions you can ask me why what. This is how people ask. Okay. So 1/3 hepatic artery, 2/3 portal vein. You see, hepatic artery and portal vein. The portal vein sends the larger portion of the blood to the liver, but both of them supply around 50% of the oxygen delivery. Okay, 40 to 50, 60 around that. Okay, the SaO2 artery as usual, the oxygen saturation, right? 98%, right? And 50 to 60% of VO2, SpO2 of 70%. Okay, VO2 50 mL oxygen per unit. Same like brain, yes, but 20% of your total body VO2. Okay. So liver blood flow and regulation, internal factor. This is portal venous flow regulation and hepatic arterial flow regulation. Hepatic artery as auto-regulation, right? Because your vessel can contract, they got edema and everything, but venous cannot. So portal blood flow is not auto-regulated. Hepatic arterial flow is auto-regulated. Okay, so portal venous flow is determined by splanchnic arterial flow. It's flow rate dependent, not by the pressure or anything. Okay, resistance changes in response to humoral signal, local endocrine signal. Hepatic arterial flow regulation, auto-regulatory mechanism by diastolic safe contraction and dilation of the vessel. Hepatic arterial buffer response, flow increases and portal venous flow decreases. It's like if, as I mentioned, 2/3 of the portal liver blood flows come from your portal vein. But if liver receives low blood flow from your portal vein, the hepatic artery will dilate to send more. Okay, especially in ill states. The 2 organs that body will always compromise first is the kidney, next is your GI, right? Your splanchnic circulation stop. When your splanchnic circulation stop, less portal blood flow to the liver. Next, you can expect your liver get ischemic hepatitis, right? If your hepatic artery does not do its job. Make sense? Okay, good. So external factors, venous return, positioning, these are all very subjective. Okay, if the patient have a congestive cardiac failure, right, there will be a congestive hepatopathy that causes reduction in portal vein blood flow as well, right? All these things. Okay, liver blood flow measurement. This will come out. I think maybe I saw one SAQ. Come on, okay. It follows the fixed principle. All blood flow follows the fixed principle method. Same thing like your output for cardiac output. The indicator they use indocyanine green. So how do they give? They give as infusion rate. This indocyanine green as whatever the tracer or indicator use, the same thing I should be inert, non-toxic, non-secreted, non-reabsorbed, non-metabolized. Okay, so the indocyanine green is totally excreted in bile, only in liver, not taken up by any tissues or any intestine or whatever. Okay, you give inside your intravenous, goes to your liver, excreted in the bile directly. Okay, so the indocyanine level at peripheral, hepatic artery or portal vein. So since it's only excreted in the bile, you give and then you take back from venous, you give blood, infusion rate, after some time you take sampling from your blood, it's the same because whatever you given is still circulating, it's not metabolized, right? So that part. Then ICG level measured in transjugular hepatic vein and peripheral. So you take one from peripheral, one from your central venous line. Okay, transjugular hepatic vein, peripheral. So it follows the spectrophotometry. This is how the flow rate divided by ICG peripheral minus ICG HP. Okay, no need to know in detail, just know this much. Liver function, I think you all know this. Metabolic exocrine, make sure you divide it into four of these and give you example like that. Okay, I have seen one question came up, 2 marks. Describe the functions of liver. And another one is liver function test, something like that. Okay, I think, but not new test, all the old testing. Next about bile, it's made in liver. From the liver, it goes to your right and left hepatic duct, common hepatic duct, then goes to your common bile duct, goes to your gallbladder. Right? It stays in gallbladder. If you want to come out, it goes to cystic duct and goes again to common bile duct. So it's around 500 ml per day, very alkaline, contains water, bilirubin, bile salts, and electrolytes. Function, digestion, absorption of fats and vitamin, excretion is primary and secondary bile acid. This question came out in 1999. But it's written in your syllabus. So I have to cover that just in case, I don't know. Somebody try to go up again in the, I don't know. Primary and secondary bile acid is given in Kerry Brandy's. What is fat soluble vitamins? What are the fat soluble vitamins? Okay, good. Just mention that also good. Okay, that's all.